Well, I think one of the things we both agree on is that this year Australia used the best available vaccine that it could buy, and that was the QIV vaccines that were given to everybody. We've seen over the last 5 to 10 years an increasing difficulty of that particular vaccine dealing with H3N2, the particular strain that affected the elderly this year. It was very poor in the US on a number of years. It's been poor here. The vaccines that we were talking about that are in fact enhanced vaccines have been used for over 2 decades in a wide range of countries in Europe. The adjuvanted vaccine, the high-dose vaccine, was more than 60% of the elderly in the US last year. It's likely that both will be available in Australia next year. We're very gratified to hear the Chief Medical Officer talk about the work he's doing with the companies to make sure they come in here. There have been lots of important community studies with both vaccines, and while there's only one randomised controlled trial, what's important is, do these vaccines actually work when we give them to the elderly here?
But your suggestion,
there's
apologies
data from the US.
for interrupting, but your suggestion was that these enhanced vaccines that weren't used were not used because they were more expensive.
Well, I mean, they weren't used because we didn't have availability this year. We will have availability by the sounds of it next year. We want the government and industry to work together so there's a reasonable price that the government can afford to make sure that we provide better protection. We're talking in a number of studies in the US and through Canada about somewhere between 20 and 30% increased effectiveness and a doubling of the protection against hospitalisation. These are very large community-based studies. They can save us tens of thousands of hospitalisations in the elderly if we get that again. It's one of 3 really key policy changes that we need to make before next year to provide better protection for our people.
One of the big drug companies, Sanofi, has come out with a statement also saying that your contention that a cheap vaccine was to blame for the bad flu season was wrong. They say suggestions that the high rate of influenza in Australia in 2017 are in part a result of the supply of cheap vaccine is incorrect. Do you regret now saying that?
Well, I think the focus of the discussion with the News Corp journalists was on what are the policy changes that could be made going forward. One of the focuses was we are one of the few developed countries that does not provide free vaccine for children. I'm excited that Queensland's become the 2nd state to offer free flu vaccine next year for children. We know that when you give vaccine to children and when you provide it for free, that you stop the elderly getting infected as well because they stop giving it to their grandparents. I don't understand why we can't get a national policy to provide free flu vaccine. I think that the debate about, the cheap vaccine has taken the focus away from the fact that while we used the best vaccine that was available, and while it is an inexpensive vaccine, both of the other vaccines should be available next year, and we need to be using them.
Why were
having a 4-strain
those
vaccine
vaccines
in the
available
elderly,
this year, though? Apologies for interrupting once again. Why were those enhanced vaccines not available this year?
It's a combination of issues, but the most critical issue is the commercial aspect of getting vaccines into Australia. We're a small marketplace, compared to the 300 and something million people in the US and Europe and Japan and Korea and the others using the Northern Hemisphere vaccine. They've never gone to make a high dose or an adjuvanted vaccine available in the Southern Hemisphere, and what we need to do is provide them with a commitment that we will use this vaccine and demand that in fact they bring it to Australia so that we can protect our elderly.
And if we had that enhanced, more expensive vaccine, we wouldn't have seen the record numbers of flu cases and deaths that we had during this last flu season over the winter.
Absolutely. We've seen data that showed that in a 3-year Canadian study, the adjuvanted vaccine doubled the protection against hospitalisation. Similar data out of administrative data with the high-dose vaccine in the US. Some data from the US CDC said that for every 5% increase in the effectiveness of vaccine, they saved in a bad year 86,000 hospitalisations. We know these are more effective. We've got the community studies that show that in the real world setting they're more effective. Had we used them this year, we would have had better vaccine effectiveness and we would have prevented them. But we couldn't because they weren't available. they will be available in the future, and we're really keen to make sure that the government and the companies work together to make sure that they're available.
And you're on the from the Immunisation Coalition. Whose decision is it which vaccines are used for particular flu seasons?
Well, the vaccines, the strains in the vaccine are decisions made by a very technical, professional WHO reference group who monitor the actual genetics of what's circulating in the vaccines. Sadly, they have to make a decision because of the way we make vaccines 10 months before the next flu season hits, so that we're already committed to the strains. From there, the decision as to which brand of vaccines are used, or whether we use high dose or adjuvanted or QIV or TIV, is made by government bodies. They're made by the PBAC and the TGA. The TGA licenses the vaccines, and the PBAC decides what money is worth spending on different vaccines. So the actual composition is a professional process via WHO. The decisions are made by the federal government as to what they want to do from there.
Professor Paul van Binder, thank you so much for being with us.
Pleasure, thank you.